regard, I'm a pediatric gynecologist. I work with 2 other pediatric gynecologists. We work out of Valhalla, and we have several satellite offices in Westchester. I think it's sort of beginning with this talk to let you know that on Wednesday, one of my partners was in the OR calling me that she had a 12-year-old who she had gone in for with an ovarian cyst and looked like she had scattered diffuse endometriosis throughout her pelvis at age 12. So it is a disease that can strike very early. We're waiting for the biopsies to come back, but we're thinking that with the way this looks surgically, this is most likely going to be endometriosis. So I'm going to talk a little bit about how we, as practitioners, as pediatric gynecologists, handle a patient who comes into the office with pain and how we work through. Of you who don't know what endometriosis is, who are new to the topic, it's considered endometrial tissue in the wrong place. So I now describe it to my teenage patients, because they often want to know why I can't see it on ultrasound, as blisters or chicken pox place. And so I will say to them, you know, it looks like you have like little chicken pox blisters around, because that's what it's going to look like generally in adolescent. Endometriosis should be viewed as a chronic. Girls come in with 17 laparoscopies by the time they're 25. So the girl presents to time, try the other one. There are those specialty patients who either have gastritis or may have von Willebrand's disease. We have a lot of girls in our practice with von Willebrand's disease, and they technically are told they cannot use a non-steroidal, but they can use Celebrex. So those girls, it's good to remember, who may have been told, oh, I can't use any Motrin because I have von Willebrand's disease, Celebrex is okay for them. There was a very nice study done on omega-3 fish oils. There was somebody who had determined that because of the inflammation in prostaglandins, the way it comes down the arachidonic acid profile, that maybe fish oils would block some of the prostaglandins produced with dysmenorrhea. And so they actually had a very large study of 750 girls with dysmenorrhea in high school, and they gave them fish oils every day and found out that they reduced the amount of dysmenorrhea complaints. And as a side, there's also good studies showing that it helps with ADD. So there's always advantages to taking your fish oils every day. I use a fair amount of lidocaine patches in girls who we don't want to put on the pill just yet, who have some discomfort, and I've had some reasonable success using lidocaine patches in the early stages, or I will use it post-surgical stages just to complement. I always tell people I just want to layer everything on, so it's a good thing to know about. It's not been proven. There are some lifestyle suggestions. Smoking has been associated with prolonged dysmenorrhea, so counsel them for all sorts of reasons to reduce their smoking. Obesity, we have had, I think it's a trend that there's probably more inflammation in obese girls, and so I think there is some feeling that we're seeing more obesity, more endometriosis in obese patients. It's not been worked out that well, but we do have some studies suggesting that being overweight may, with all that inflammation, may increase. I think they'd get disease anyway, but it may be worse with obesity. So you've started with NSAIDs, and they're still complaining that they're having pain, and they say, you know, now I'm really, really ready. I need to go on to birth control pills. So endometriosis and hormones. Endometriosis is considered an estrogen-dependent disease, so medical therapies are targeted at lowering their estrogen. We usually start with cyclic therapy and nonsteroidals in any female patient with pain. So progesterone is the workhorse of the birth control pill. What's very interesting about progesterones is progesterones produce an anti-estrogen effect. They inhibit endometriotic implants. But what's fascinating to me is I attended a lecture on the use of progesterones for preterm labor. And they have an incredible anti-inflammatory quality, and that's why they're starting to use them in preterm labor. And I'm starting to suspect that there's not been a lot of cross-pollination between OBGYNs doing research in preterm labor and people doing research in endometriosis. But it may be that there is an anti-inflammatory quality to progesterones that helps with the inflammation of endometriosis. And I'd love to see these two research groups cross-pollinate to look at the anti-inflammatory qualities of progestin therapy. So we usually use a traditional pill that has a combination of estrogen and progesterone, because when a girl goes on pills, her natural estrogen levels will suppress to very low levels, and she will not have enough estrogen to bone build very well, and she's in her peak bone building years. So we have this dual problem of we want to lower your estrogen, but we don't want you to have osteopenia by the time you finish treatment. So you want to be in a double therapy, and there is newer stuff coming out saying you need to be on a 30 to 35 microgram pill for good bone building. So that's a unique need of adolescent patients. We do have the NuvaRing, and we have the skin patch each week. I don't typically pick those therapies for endometriosis in teenagers, but they're available. Monophasic is much better, I think, than triphasic. We want the therapy to be the same every week. We don't, orthotricycline, triphasal, those, I'm not a big fan of triphasic pills in adolescents because I want it continuous. And later I want to use, I want to do like 6 weeks in a row or 9 weeks in a row for a lot of these patients, and I can't do it with a triphasic pill. Progestin dominant, these are some of the progesterones that are better and more progestin dominant that would be more efficacious in endometriosis. So dosages, again, I hinted that we really want to avoid 20 microgram pills in adolescents. While it would be better for their endometriosis to probably be on a 20 microgram pill, in those years, unless we absolutely can't manage, and there are some conditions we have trouble managing on a 35 microgram pill, we want to try to stick to a 30 to 35 microgram pill. But you are going to have more side effects with that. Headaches can be one of the predominant reasons you can't use a 30 to 35 microgram pill, and there is more. Migraines are more associated with patients with endometriosis, so we get more kids with migraines who have endometriosis, so we have to factor that in. Fluid retention, nausea, weight gain, some hypertension, emotional liability, those are just the things you may get with a little more estrogen. Now, you'll have the girl that can't take estrogen. So there's been several consults where, like, I have terrible pain. I'm trying to take birth control pills, but every time I do, I have blindness in my eye with my migraine, something like that. I don't know what to do. Well, those girls can take progestin-only therapy. So if she has a risk for a clot, her mother had, a blood clot, and she got tested and is known to be a carrier for factor V Leiden, for example, complex migraines, that's anybody who has migraines with neurologic focal symptoms. So if you have a migraine and during your migraine you can't use your arm, or you can't speak, or you can't see out of your eye, that's considered a neurologic symptom with your migraines. That puts you at increased risk for stroke with birth control pills. And those girls should not be on estrogen-containing pills because of their increased risk of stroke. And that certainly applies for adults as the risk goes up. So they need to be on a progestin-only therapy. And then there's girls with persistent nausea or headaches that just aren't doing well, and they would switch over to progestin therapy. So for progestin therapies, we have the mini pill and the Norgestrel, which is Avret. It's very hard to get on the market. So typically Micronor, which is this breastfeeding pill that was developed for breastfeeding. And then you have the Depo-Provera, the IUD, and the implant. My problem with Depo is after 2 years there's an osteoporosis warning, so I don't really like to use it in adolescents because, again, they're bone building, and that's got to be laid out against all the other things we're trying to do. I love the IUD. I'll talk about it quite a bit later. And you should be aware there's a new 3-year IUD that came out on the market, Skyla, in addition to Mirena, and it was so popular they ran out after 4 months. And so they actually are in back order, and they're having to ramp up all their manufacturing because they just whipped through them much quicker than they expected. And then there's the implant, which lasts for 3 years. I don't love it for endometriosis patients because there's unpredictable bleeding with the implant. Great contraceptive, but if you're already bleeding and in pain every time you bleed, unpredictable bleeding doesn't really help you. So dysmenorrhea, we're going to, kind of work through, again, we're going through the different hormonal things. And then when should we consider laparoscopy? So the American College of OBGYN recommends that if pain persists beyond 3 to 6 months, you should consider doing a laparoscopy. If you're under 18 especially, if you're over 18, you have the option to give the patient Lupron for 3 to 4 months and see if the Lupron handles their symptoms appropriately, and then they can go back on pills. I've had some issues with the Lupron in that my patients find that they're really wanting to know a diagnosis, so they don't love the idea of like, maybe I have it, maybe I don't. They just really want to get that settled. They've usually had pain for years, and they kind of feel like they want to get to the bottom of it. Also, anxiety is a major side effect of Lupron, and I just had a girl 20 this year. We had the long talk, and she said, I'm going to do the Lupron, 2 shots of Lupron, and her anxiety was just through the roof, and she's switching over to surgery. When to do it, we're more likely to be concerned if there's a family history of endometriosis. If you've gone to the ER multiple times and they keep telling you had a ruptured ovarian cyst, but you look at all the ultrasound reports and there's nothing but except a little fluid in the pelvis. Fluid in the pelvis is normal, and ERs discharge kids all the time saying she had a ruptured cyst because it sort of answers their questions and nobody talks anymore. But a little fluid in the pelvis and you had a ruptured cyst and that's why you had pain and no evidence of a cyst on ultrasound is likely to be, if they have dysmenorrhea, you should be thinking about endometriosis. Not going to school. We had a 10-year-old last year who hadn't been to school for 6 weeks, and I scoped her because she hadn't gone to school for 10. I didn't want to do birth control pills at age 10, and she had a little spot of endometriosis. We took it out, and she was back in school. Really early painful periods would be a concern for endometriosis. Really focal tenderness, like a very specific spot with painful periods. It's unclear to me that, because we don't scope those kids very often, that if you have pain but no painful periods, it's almost never endometriosis in at least teenagers. Dysmenorrhea, painful periods really has to be part of the whole picture. Endometriosis is getting worse and worse, and then pain when you're not having your periods plus painful periods, these are all things that make us more suspicious of endometriosis. We think that the hereditary rate for endometriosis is considered about 35%. Should you take it out or should you buzz it? This is a big debate. The Endo Foundation has their very strong feelings on this. There are other organizations that feel differently, but this would be a typical, that little blue kind of lesion that you see smack in the sort of slightly to the right of center, is an endometriosis lesion, kind of typical of an early small lesion. I have, adopted the excision technique when I can. There are some times when you just can't quite excise, and I'll ablate. And this is what it would look like. This is a different lesion. I didn't have a post-op lesion. And this is what it looks like after we've excised. This is more down in the cul-de-sac. What you're looking at in terms of, I think I have a pointer, but there's an arch here. You can kind of almost see the St. Louis arch. Those are her uterosacral ligaments, and we're now down right on top of her vagina. That's kind of one of the typical lesion areas that you'll see in adolescence. So now if we've done our surgery and we have now kind of diagnosed the disease, I'd like to get at least 5 years out before their next surgery, if not longer. So we want to consider the age of the patient, the severity of her symptoms, the side effects of the medication we might be prescribing, how much disease we had. We're more likely to use Lupron if there was a lot of disease and we feel like we couldn't get it all. Sometimes it looks like what we call petechiae. It just looks like somebody put very tiny little dots everywhere across the pelvis. We're not necessarily going to be able to strip out every single little dot, so we're more likely to use some follow-up Lupron. We want to limit the progression of the disease. There's pretty good work suggesting that medical therapy limits the progression of the disease, and we want to achieve pain control. So medical therapies after endometriosis has been confirmed, the FDA has approved Lupron. They've approved norethindrone, which is agestin. You can use it anywhere. It comes in 5 milligram tablets. You can use it from 5 to 15 daily, so 1 to 3 tablets, although we're careful. The more you get some metabolic issues, some insulin resistance, I think, as you move up that scale. And then danazol, rarely used in teenagers, but has been approved. And then we're going to talk about some non-FDA approved therapies. So the mechanism of action for Lupron is that it sort of overstimulates the pituitary, and then after about 21 days, you have complete suppression. For any nurses that work with patients who might have other issues like cancer, we work with bone marrow transplant patients in our hospital, so we have to be very careful to have them suppressed and have their platelet counts and all that not going to zero right when they're having their flare and about to bleed. So there are other situations where we're very aware of this 21-day suppression issue, especially in our pediatric oncology patients. And then usually this should be flat after that and have little in the way of bleeding. We do give add-back therapy with agestin to protect their bones because of the risk of low bone density with this. There's different formulations. The average one is going to be just a shot every 1 to 3 months. I use the nasal spray in some patients with migraines where we want to go up a little bit slower. Side effects, again, hot flashes, some complaints. Headaches can be a lot if they have a pre-headache history, especially. Vaginal dryness hasn't been a big complaint from teenagers. Decreased libido, not a very expressed complaint from teenagers. Anxiety, big complaint. Big complaint with it. And I always warn them that this is something they have to think through carefully. If we have a lot of endo, we just have to chug through it, and they know they have endo and they just chug through it. If they don't have the diagnosis yet and they're 18 and they're choosing it instead of surgery, it's a part of the counseling. And then we need to think about bones. So add-back therapy is very important. It will stabilize the bone density. It helps them with a lot of their symptoms. And sometimes they'll stay on add-back therapy even after the Lupron's gone because the agestin alone can be a good treatment. So vitamin D, there's a lot of focus on making sure everybody's vitamin D level is good during treatment. These are just some slides to remind you that if it's low, you can treat with 50,000 units once per week. Sometimes easier for compliance, but keep their D levels up good while you're working on these therapies. Norethindrone alone is an anti-estrogen effect, and I think, again, we may find out later it's an anti-inflammatory. That work is all in preterm labor. This is how you can use the tablets, and these are the side effects, but I think we did have one girl, we were using it for a different indication, and she was needing 3 a day as a Jehovah's Witness who was bleeding, and she became diabetic under our watch at the hospital. So, you do have to be careful about how you're using it. Danazol, I'm not even going to go into this slide, but it's there if anybody wants to look at the talk later on. Mechanism of action, side effects, we just don't use it that much in teenagers, but can be very, very effective. Non-FDA therapies, we have Depo-Provera certainly works, but again, I have the bone issue concern. Aromatase inhibitors, don't see it used much in teenagers, but does work. And the IUD is really, I think, the new player on the block. So the Depo-Provera is going to decrease your brain hormones of LH-FSH, which is going to prevent your follicle maturation, which is going to lower your estrogen levels. Can be given as 150 or 105. They were really hoping the lower dose would help the bones, and it does not. That was really sad when they finished the research. It's not any better for the bones, and it's more expensive, so it's hard to get insurance to pay for the lower dose. So the patient may like the idea of having less hormones in her, but we can't statistically say it's going to improve bone density. Aromatase inhibitors basically help with the expression, let's say the rise in local biosynthesis of estrogen, help inhibit that. We use it in other indications where their ovaries might be independently producing estrogen and their brain's not involved, and it blocks the compounding result to estrogen locally in the ovary. It can improve pain scores. You would add it. It needs to have contraception with it because it can cause sort of spontaneous ovulation, and bone loss is a risk. So the IUD. So the primary lining mechanism is thinning of the lining and stabilizing the endometrium. It's FDA approved as a contraceptive, and it's FDA approved for heavy periods. That I should tell you, the Mirena is FDA approved for heavy periods. The Skyla is only approved as a contraceptive. It's off-label, however, for pain, endometriosis. We use it in developmentally delayed adolescents who need help with menstrual hygiene and might have seizure disorders, and we want to use less hormones in them. Used in uterine hyperplasia, and they've reversed some uterine cancers in young women who, let's say, have polycystic ovarian disease or overweight, and at 19 show up with uterine cancer. They have put an IUD in and been able to reverse their cancer and keep them from having hysterectomy. Pilot studies began in 1999 with endometriosis, and the first 20 patients looked good. So they went on and compared them to, let's do your surgery, or let's do your surgery and put an IUD in. And they found they had 75% of women who were satisfied compared to 50% who had only surgery. We know that women who have surgery for pain at 1 year, 50% will report their pain is back. So we know that surgery alone is not going to hold their pain. Levonorgestrel compared with the Lupron showed to be equally effective in terms of pain scores and less side effects. The IUD bleeders do have more bleeding. I tell them it's 6 months, it's a little bit rocky, a little bleeding every day. However, in the end, you have 4.5 years of not taking a pill every day. Usually they weren't doing well on pills when they came to me because we've already tried pills, and things should be good. And we're really happy with we've got about probably 10 girls now out in the community with their IUD post-endometriosis surgery, and we're really, really happy with what we're seeing. The biochemistry of it is just how it compares to Lupron. And again, it has some, which is very interesting where you see the red knots, it really has, seems like some anti-inflammatory qualities that the Lupron doesn't have, and I think that's where the IUD advantage is going to be. So using it in adolescents, everybody's been really, it's getting more popular, but everybody's still been really nervous about using IUDs in adolescents. But the advantages are you don't have to take a pill every day. There's no effect on bone density, which is what a huge, huge help is. And then there's no significant effect on your lipids. The disadvantage is the first 4 months, really, you got to really warn them. It's going to be rough. It's going to be bleedy. You know, you're going to be okay. Pain of insertion, so is always an issue, especially if these girls are already hyped up about pain. They already have a lot of pain issues to begin with. So I find that sometimes it just kind of triggers that cascade of that pain for them. So we try to insert them at the time of surgery. So if we go in and we say, look, you're not doing well on pills, we think you have endometriosis. When we're there, if we see endometriosis, you should have an IUD. If we don't see endometriosis, you should have an IUD because you're not doing well on pills. You should at least switch therapies. So we try to then do our surgery for the endometriosis and then put in the IUD at the time of surgery. Paige Hertwig did a study looking at IUD at the time of surgery or IUD 3 months later. It takes a little bit longer for the bleeding to resolve if you do the IUD later. If you do the IUD at the time of surgery compared to later. But I think the girls would tell you it was well worth the trade-off just to not have the IUD put in the office. Not that they can't do it, but it just, it's a little more painful for them given their history of pain. Expulsion is there, slightly higher for adolescents, and everybody worries about perforation. I'm going to show you, we have 3 studies of girls 21 and under, 200 in each arm, 200 in each study. There were studies across many age groups, but they isolated out the 21 unders, no perforations. So that's a big fear of the moms, and it's not really worse. Obviously, STDs there is a risk, but just because you're a teenager. I'm saying it's not higher because you're wearing an IUD. So this was one study looking at menarche to 21 receiving IUDs. These were some of the complaints. So 21% wanted it removed. Those were usually girls under 18. We've been a lot more, our endometriosis patients have been a lot more motivated to keep it in because they already were crummy before they had it in. So they're more likely to hang in there. Expulsion's a risk. Difficulty with insertion, unable to insert, then we'll take them to the OR. Infection, these were, again, I think some of these were in an STD clinic. I think, yeah, actually about 2/3 of these were in a family planning clinic. And again, no perforations. These are some investigational drugs that are going on for endometriosis. And these are, and Botox they're looking at as well. We're looking at, because you get a lot of muscle spasm when you have endometriosis, so we send our girls on to physical therapy afterwards. And Botox is being in a clinical trial at the FDA for some of that muscle spasm. So hormonal therapy is really, I think, a very important component. I don't want to operate on a girl and say, let's see what happens next. I really want to operate on her, get the endometriosis out, and get her on something. And I really try to encourage families that I think the IUD is their best option, given that they've almost always been on pills prior to us going in for surgery. And you want to weigh out their age. My 10-year-old, I didn't want to put on hormones. I put her on Lupron instead. Then she had a horrible migraine, and then we just said, we'll just, see how it goes. So you've got to factor in age, especially with the adolescent, and their impact on bone density. So the Cochrane Review has demonstrated that women are 5 times more likely to benefit from surgical management. I think we all agree that surgery is a really, really important component of therapy. The risk of recurrent lifelong disease is high, especially in the adolescent group. And we know now that combined surgery and medicine in this German study that came out this past summer, which I don't have in the slide, 150 in each arm. We could never do this study in the United States. They actually re-laparoscoped like 400 women a second time and compared them to medical therapy, surgery therapy, or combination. And the least amount of lesions were in the combination therapy group. So we really want to put in that. And then each young woman has her own unique history, her own unique findings. We have one girl who's 300 pounds. We couldn't even take it out because the weight was so intense that we couldn't move our instruments. And she is now been on Lupron continuously for a year and is now having bariatric surgery. I re-biopsied her on with a bariatric surgeon when he went in to do her stomach sleeve, and her lesions are down by like 75% with just the Lupron, and then I took out more lesions, and I told her when she loses 100 pounds, I'll go back in and take out more lesions. So she was a really unique case of kind of doing it in steps off kilter. She was 18 when we made her first diagnosis, and it was everywhere. It was like sludge on her colon, and now it's down to like little pinpoint areas, and we didn't even touch the colon. So everybody's unique, and concerns need to be considered to optimize medical therapy for that girl. So I can take a few questions if anybody has them. Yeah.
I'm curious about the von Willebrand you said that you like.
Well, we just have patients with, we have a hematology clinic, so it's not that it's necessarily, but it is tricky. We've had a couple with von Willebrand's and endometriosis, and sometimes they had like irregular bleeding, so that was, and then they'd have pain, and it took us a while we have one girl who, had seen her adult gynecologist who's like, oh, you have breakthrough bleeding on pills, menstrual pain, you have menstrual pain. Finally, she switched into my practice at about 15 after a year of being told by the adult gynecologist that's just what happens on pills. It took me a while to put it together, but she had von Willebrand's disease, so that's why her pills weren't really working that well for her. And she had endometriosis when we kind of, took us a while to finally get to a scope, but she had endometriosis, and she had seen GI doctors and adult gynecologists, and there was a lot of, but it just kind of took us sort of pulling it all apart. But mostly because we have a hematology clinic do we see more girls with von Willebrand's. But it is 1% of the population, so it's there much more than people realize. Yes? I have it with me. I'm thinking I could read that. I've got it with me. I'm thinking they used excision, but I've got to look. I can look in the method section if they tell you. Probably a combination. But it's the first study. We'll never see it done in the United States where they had 350 in each arm and re-laparoscoped like 80% of these women at 6 months, which was quite extraordinary. Other questions?